All right. Oscar.
Jonathan, thank you for having me.
Welcome.
Yeah, it's really great to be here.
Yeah, this is our first live stream from the new studio here for the Protected Airway Collaborative. I'm super excited that you're our first airway expert, and we're doing a topic that I love. What are we doing today?
Well, first of all, it's an honor and a privilege. It's just an incredible space. What a vision you have to be here. So today we're going to talk about HALO procedures, so high acuity, low occurrence procedures. And we're going to focus on one in particular, which is massive hemoptysis and the placement of a bronchial blocker. So lots to cover and a really high acuity, high impact topic, I think, that our viewers will enjoy.
Yeah, I think for all of us in critical care and pre-hospital and emergency medicine, you know, the HALO procedures are something that we all have fear of, right? And I think, you know, one of the reasons why I created the Protected Airway Collaborative was to come up with ways of tackling that fear and those challenges of the high acuity, low occurrence procedures like surgical airways. Massive hemoptysis is another one.
Absolutely.
And so I think we have a really great show on tap that's going to kind of break down a little bit of how we go about creating a strategy for training ourselves regularly, right? I think one of the big roadblocks is accessibility.
Absolutely, absolutely.
So the first part of the show, we're going to sort of highlight the 3D printed model that you've made, which we played around with it like an original version, like a pilot version at PAC 25.
Yeah.
And it was a lot of fun, and everybody loved it. And today we have sort of an updated version, and we're going to showcase what it is. It's low cost, that people can print it up themselves, that it's easy to set up. And then one of the big pieces of this puzzle is that if you have pretty much any throwaway, practically airway trainer, and you just want to put this on, you can practice training for massive hemoptysis, right?
That's exactly right. I think with any of these HALO situations, the procedure itself is just part of the orchestra that needs to happen. But unless you know the pieces to the puzzle and the sequence of putting the kit together and placing that kit inside the patient, it's going to add many, many layers of stress onto an already extremely stressful situation. And so, you know, you and I and other members of the PAC have worked together to develop this very low barrier to entry model, which can be used in any measure of fidelity to real life, and can allow you to practice in your own shop and be ready for your next emergency.
Yeah, I think we should mention Jim DeCanto as
Absolutely.
as the godfather of massive airway contamination, and this is an extension of his work. And I think that this is, if anybody has done the salad technique and understands how useful it is, I think this is just going to be another great addition. Like when this topic first came up, when Jim was like, I think we're going to try to create this 3D model, and I was like, oh my God, of course, why haven't we done this already?
Now it's just the tube next to the one you're trying to put the breathing tube in, right?
So what's the plan for today? We're going to showcase the model.
We're going to showcase the model, and we're really going to go through each of the pieces and how they can be assembled.
Okay.
We're then going to talk about airway decontamination after the endotracheal tube has been placed. So some suctioning techniques and ways to remove massive amounts of blood from an airway. And then we're going to go through two endobronchial blockers. Okay. So the ARNT blocker and the uni blocker.
Okay. Yeah, and everybody has something different at their institution, but these are two very common ones. I think if we go through how to set them up, that'll be great.
Fantastic.
Okay. Yeah, and then I think the beauty of this is the beginning of creating sort of a PAC-style curriculum, right? Where we're going to have the digital content online, we're going to have the interactive content available, we're going to have the 3D printed model that people can use, and then what I'm hoping is that people will start using that to set up their own trainers in break rooms, in resident rooms, in faculty lounges, and training for this high acuity, low occurrence procedure on a regular basis, so that when the time comes to do it, you're not struggling with all the cognitive load that comes with being unprepared.
Absolutely. Hemoptysis for the people.
That's right. Democratizing
hemoptysis. Right. Reclaim the airway.
So should we get started?
Absolutely.
What do you want to start off with first? Do you want to start off by just showing the model and demonstrating it?
Yeah, why don't I show people how the model comes together and how we've done this particular model, and then I'll invite my glamorous assistant Ethan on to go through the airway decontamination and bronchial blocker placement.
Sounds great. Let's do it.
Outstanding.
There we go.
Great. So this is the centerpiece of the bronchial blocker or Hemoptysis sim. This is a 3D printed airway model, obviously in a beautiful bubblegum pink, which ends up looking very nice on the endoscopy bronchoscope. You'll see that on... So this is the centerpiece of the 8 individual pieces of the bronchus. There are lower lock pieces here. That allows installation of blood into any segment of the bronchus that you want. So as we're doing the simulation, each of these has a cap on the end, except for one, where the blood will be instilled. You can, literally, all you need to do this is an endotracheal tube and the 3D printed bronchus. And I'm just going to try and find, oh, here's my syringe. You can inflate the balloon. Which creates a closed system where you have an endotracheal tube and then an airway. And this really is all you need to practice the process of bronchial blocker placement or airway decontamination. You'll see that that's an airtight hole here. So if I invite Ethan to come here and hold the endoscope, he can then pass that down the endotracheal tube. And you'll see you have a realistic airway model that can be used to train for bronchial blocker placement. So that's really it. And you can evolve from that to a more high fidelity model, which we have here, where you have, as you see, a mannequin head that's already been intubated. It already has a commercial endotracheal tube holder on. And all we did was decapitate a CPR dummy and then transect the trachea and insert it into the trachea model here. And so you have an almost realistic, life-sized torso that, as you will see later in the podcast, live cast, will simulate really a very, very realistic model of bronchial bleeding. Okay. So the patient has presented to our intensive care unit or to our emergency department.
I'm just going to jump in because I want to be part of it.
Oh, absolutely.
We only have 2 mics, but I think if I stand here, everybody should be able to see me. So just keep going.
Okay. No pressure with you over my shoulder. So this patient has presented to the intensive care unit after being seen by Dr. St. George in the emergency department, who successfully intubated him with either an 8.0 or a 9.0 endotracheal tube. You'll see as we go that you're putting a lot of stuff down the endotracheal tube. A smaller tube, kind of a 7 or a 7.5, is going to be really, really tight. It's already pretty sticky down an 8. And you really want to be able to work and ventilate the patient, I should say. So this is Ethan, who's going to be part of this process. Our first move is going to be to perform bronchoscopy on the patient. You'll hear some noise now as I turn on the suction device. And you'll see our first purpose of the endoscopy is to locate the source of bleeding and to clear the airway of blood, of contamination. So Ethan's going to go down the left and he's going to look around. And as you can see, there's really not a lot of anything going on. Sometimes there's some blood that, oh! And now we see a massive amount of blood that's come from the right side. So Ethan's first job is to clear this airway of blood so that we can see what's going on. You'll see he's taking a very thoughtful approach. He's going to the distal airways. He's then suctioning and pulling back and clearing as much blood as he can. As we proceed through this, as the patient continues to bleed, you may notice that clots start to form, which can be harder to remove. And ideally, you can remove them through suction, but these patients can be very, very challenging. So Ethan's gonna now manage to clear the airway enough, and it doesn't have to be perfect, but we could be confident that it's the right side, maybe from the right lower lobe that's bleeding. So with that, he's just gonna clear it out a little bit more. And once he's happy with the view that he has, he's gonna remove the scope, and we're gonna start planning for endobronchial blocker placement. So, we're now going to take a moment to go through two commonly used bronchial blockers. You'll notice that this is a very busy process, and while one person is cleaning out the airway with the bronchoscope, an ideal situation is that someone else who's familiar with the product is assembling the blocker and the tree as a complex, ready to switch in rapidly. Because in an actively bleeding patient, you can lose your view very, very easily. So, Ethan and I are going to put this together. You'll see that this is the Cook model, the ARNT blocker. There are 3 ports. This side port connects to a ventilator, so the patient can be ventilated during the emergency. This diagonal port is where the bronchial blocker is inserted. And then this is where the endoscope goes through as well. So what we like to do is to place the bronchial blocker all the way through, and you'll see why in a second. We're then going to place the bronchoscope through the bronchoscope port, and there's a loop here which has to go around the bronch. And you'll see it is very fiddly. And in an emergency, you really don't want this to be the first time that you've ever tried to do this. So I really encourage everyone, if this is the model that you have, to make sure that you get to grips with it and learn how to do it. So you'll see that the loop of the lasso is around the bronchoscope. Ethan is then going to pull it tight, so the lasso is tight around the bronchoscope. He then needs to hold the distal end of the endobronchial blocker in a simian grip, holding traction so that the bronchial blocker moves with the endoscope at all times. At this point, you'll communicate with the individuals performing the cleaning endoscopy. Remove the bronchoscope from the endotracheal tube and place the tree, is what it's called, down onto the bronchoscope, and then connect the patient to the ventilator, like this. So you can ventilate and then work on placing the endobronchial blocker. So with that, Ethan and I will communicate as we place it.
All right, ready?
Yep.
I don't know if we made it completely clear that this is our second bronchoscope. It's a 2-bronchoscope process.
Yeah, you really want to be using a large bore bronchoscope, so as big as you can find, because those clots can be very hard to suck up. Okay. Here, Ethan and I are using a slim bronchoscope, which will allow us to go down the 8.0 endotracheal tube. The larger scope would be very, very snug and may not even go at all.
Okay, ready.
All right, so the next step is to loosen the lasso and then advance under direct visualization into the airway that you want to block. And then, with the bronchoscope showing us where the balloon is, we're going to inflate the balloon slowly such that it completely occludes the bleeding bronchus. We'll then see cessation of active bleeding, and then Ethan can remove the bronchoscope. We will lock the bronchial blocker in place by turning clockwise, ventilate the patient, and then send the patient for definitive intervention, such as IR embolization, surgical repair, whatever it may be. This is a salvage procedure. This is not a treatment procedure. So this is the ARNT blocker, and we'll now show you the uni blocker, which really follows a very similar process, but is different in important ways, which is, again, important thing to know before you're doing it in an emergency. So the uni blocker is slightly different. This, you'll see, is a very similar idea for the tree. You have an endobronchial blocker here with a coude tip that allows you to rotate the tip, which you'll see once you're in the bronchus itself, to select whether you go to the right or the left main stem bronchus. It locks on to the end in a slightly different way, again turning clockwise, and again tightening up here. And then you'll see that you can connect to a ventilator, and you can place a bronchoscope through the bronchoscope port here. So in a very similar way, you're going to want to clean out the airway using a high caliber, the largest bronch that will go down there that you have available, to really suck out and clean out as much as you can. As soon as that airway is clean and ready to go, you'll communicate to your partner, who will then swap the vent setup for the bronchial blocker tree. And then this coude tip goes down and can be followed by the bronchoscope. And this takes a slightly different procedure. You'll have seen that with the last bronchoscope, because the lasso was connected to the endoscope, you had to move them together. This one, the bronchial blocker can move up and down separately, and it navigates by rotating that coude tip from side to side, if you want to go down the right or if you want to go down the left. So we'll go down the right again, and we'll move it into place, very, very similar to the other one. Thanks for the bleeding there. We can then inflate it to obscure the airway. I'll turn the suction on so that Ethan can clean it. And you may need to switch out to the other bronchoscope here. We'll see if we can clear it out with this. For those not super familiar with bronchoscopes, the suction port is on the right side of the screen. So you always want to put the blood on the right side of the screen, because if it's on, because that's where you're going to be able to suction away with. So you'll see Ethan's doing nice pulling motions, going distal to proximal. That blood is obscuring his screen. So at this point, you would try a flush of saline. And if that didn't work, often you're having to come out of the airway, clear the screen, flush through the working channel, and these can be extremely stressful procedures. Again, you've now achieved adequate hemostasis, and this patient can then be rushed off for a definitive procedure. Now, it should be noted that what have we done here? We've obstructed a main stem bronchus. This patient is now going to effectively plug off the entire airway distal to this. So people can get very, very hypoxic after this and get very, very sick. And so it really is just something that buys you time and allows you to get that patient to a definitive location and definitive care. And that is placement of bronchial blockers in a bronchial bleed.
Awesome. We're still live.
Great.
But I think people should be able to hear me, because even if we have the two mics here, it should be fine. A couple people had questions.
Sure.
So when you're placing the endo blocker, does it always go inside the tube, or?
No. So there's an alternative approach whereby you leave the tube in situ. So as it were, you're bronching through that. It is then possible to use a standard video laryngoscope to guide passage of the blocker past the balloon of the endotracheal tube. Sometimes you have to deflate it a bit. And then it can be guided outside of the, so through the cords outside of the endotracheal tube. Okay. I hope that makes sense.
Yeah, yeah. I mean, when I was watching this, it really looks so realistic.
Yeah.
And it's a 3D printed model with pink plastic, right?
Right, and it really looks and feels very similar to true life. You know, I think the difference is the true, actual blood will coagulate.
Yeah.
It can be much harder to clear the screen. It looked very easy for Ethan to do, but blood can be very viscous.
Yeah.
And it can be hugely scary and overwhelming in the moment. Yeah. And I think it needs to be said that this is a life and death situation. These patients are astronomically sick. It tends to be arterial bleeding. So this is not something that we do on our own. This is something that we're doing while our friends are coming, whether that's interventional pulmonary, thoracic surgery, ECMO, all of these different services who are going to help try and bridge this patient to a successful outcome. This is just what we're doing to try and buy ourselves time while the troops are rallied. And interventional radiology, I forgot about them.
Yeah, I mean, that's a really good point. I mean, I think now that we have integrated video laryngoscopy as well as fiber optic devices in the emergency department, the opportunity for us to be able to do this exists.
That's right.
But I think you need to think about it like an all hands on deck kind of approach. Not like, oh, I'm going to try this, and then once I get the blocker placed, I'm going to call the ICU. Right. You're like, ICU, the critical care team's going to be there, the interventional radiology might be there, pulm, and anesthesia,
absolutely,
getting everybody, CT surgery perhaps, right, are all going to be on board.
And airway decontamination and blocker placement are just a very small part of a very big moving part. These patients can be extremely challenging to intubate. Yeah. You're putting a big tube in a very sick patient. And so you want to have your most experienced airway operator placing this tube. While that's happening, you want to have the bronchoscopes being set up, ready. And while that's happening, before you've even attempted, you want to be calling all of these colleagues to get there as soon as possible. These are often the sickest patients in the whole hospital, or at least in the department. And so you really want to have an all-hands-on-deck approach. Yeah. And that's part of why I think this Halo simulation is so important. Because if you're not ready, if you're not fearless, then you're going to be worrying about the procedure. Right. You're not going to be worrying about the big picture orchestration of a resuscitation. Right. The same goes for Minnesota tubes or any of those things. It's just a bit of the puzzle.
Right. Yeah, and I think, honestly, that's the purpose of this live stream. It's not, you're not going to watch this live stream and be like, yeah, I got this.
Yeah.
Right? Like, that's not the purpose of this, right? I think when we were talking about doing this, right, the idea was, hey, we have this new low-cost model that can be used anywhere, right? So when we thought, hey, we can make this a free, accessible resource, right? So we can provide the model, and I love just attach Luer locks to it, and then you just inject a little red liquid dye, and then next thing you know, you've got a bloody airway, and you can attach it to pretty much any airway trainer or mannequin.
Exactly.
And then the attachment is literally the endotracheal tube itself. So it's probably the simplest, most inexpensive task trainer possible, using pre-existing equipment. And then we're going to spend some time, you and I, we're going to go through curriculum, we're going to break out some of this video, we're going to put it online, we're going to give like some step-by-step instructions, and then hopefully what we'll have at the end of it is a pop-up interactive space that provides hands-on training anywhere in the world, with the digital content being the backbone and the 3D printed model as being the thing that gives you the hands-on practice.
Outstanding.
And, I think the vision would be to imagine these in break rooms and faculty lounges and resident rooms all across the country.
Absolutely, and you can learn it in a low-pressure environment, which is really fun with your friends. Yeah. And then when it happens in real life, you can be prepared.
Right. Yeah, I think we just don't have opportunity to get in enough reps for some of these things. Yep. That's just the reality. And so to have it in a judgment-free zone where you can turn on the machine, start things going, have your friends squirt a little blood in there, spend an hour in the break room, like just doing it over and over again until you feel comfortable with everything, I think it's going to be a game changer.
Absolutely. I mean, it's a low occurrence event even in the intensive care unit. And so I've found the preparation of this content and rehearsing with Ethan and some of our colleagues as well has been really made us much more prepared, made me feel much more prepared. So I hope that our viewers can also have that same experience.
Yeah. Yeah, that was really cool. That demo was awesome. Any other last minute thoughts, Ethan? No?
It's fantastic.
You guys recently had a massive hemoptysis patient that you were taking care of, right?
Absolutely, and
it was stressful?
it was very stressful, but the one thing I didn't have to stress about was whether or not I knew how to put the kit together and place the tube.
Right. I mean, I think, the first, I always like to tell the story of my second day as an attending having to do a surgical airway for an inhalational burn patient, and just not really being prepared for the amount of emotional, psychological stress that put me under and what that did to my cognitive functions.
Right.
And I think the tipping point is often, and when I do M&Ms and review cases of people who delayed surgical airways, it's often because people didn't feel comfortable doing the procedure.
Right.
And so they delay doing the cut because they want to try to find other solutions.
Right.
But with massive hemoptysis, we know what they need. They need intubation, they need endobronchial blocker to try to control the bleeding, and then they need to get somewhere where they can get definitive care.
Absolutely, and like we said, this doesn't make you a master of hemoptysis, but it makes you more confident in placing that blocker.
Yeah. I'm going to look and see if there's any more questions online, and then I'm going to come back and I want to talk a little bit about the upcoming course that you're about to start.
Oh, that would be great.
The Revive course, because I think it's going to be amazing. I'm really looking forward to it. So I want to talk a little bit about that. But let's see if we have any other questions. I'll be right back.
Brief musical interlude.
Yeah, someone made a good comment, which was add a bronchoscopic port adapter for practice too, which.
For this?
Yeah.
Yeah, so we forgot to bring one, but there's a little blue shoulder.
Yeah.
It's blue at our institution that sits here and connects to the vent. So you have kind of a 90-degree angle here, and it really functions very similar to this here. It actually often looks exactly like that, and it really is just the interface between the endotracheal tube and the rubber part there.
But I 100% agree with the person who made the comment, because I think it's you want it to feel as in situ as possible.
Absolutely.
And practice with what you have, so that's just pattern familiarity. And so we'll actually add that to the list of equipment, that you should grab and have together.
Yeah.
Cool. All right, so let's talk about Revive.
Yeah.
So tell me what it is and why you're doing it.
So one of the things that I'm really passionate about is excellence in resuscitation. And cardiac arrest is one of those events that I think can be chaotic, can be stressful, and we want to do our very best. So Revive is a super hands-on, clinically focused conference that really delivers the most up-to-date, hard-hitting, and most importantly, clinically relevant information that people can use to manage their cardiac arrest. So it's being hosted in Philadelphia at the Penn School of Medicine in the spring of 2016. I hopefully will be able to provide a link on the page, and I'm really have the amazing fortune to bring together educators from across the country, really passionate individuals to teach on cardiac arrest, resuscitation, and post-arrest care, and just provide incredible information to our attendees. So we're going to have a morning of lectures. These are not hour-long boring lectures. These are 15-minute, to-the-point, hard-hitting content, and then an afternoon of hands-on resuscitative practice, very similar to this, focused on how to do the very, very best of resuscitation for your patients in arrest.
Yeah, I mean, for anybody who doesn't know Oscar, I've known him for a few years now, and his passion for education is obvious, and I can't wait to see how you design this. When you first told me about it, I was like, oh man, it's going to be so much fun. So I think, and I agree with you, I think, for anybody who is still doing, the American Heart Association, like ACLS algorithm, right? They're sort of behind the times.
Absolutely.
And there's so much happening with resuscitative TEE and Felipe Terran's course, but I think the idea of integrating and bringing in airway management and high quality CPR and TEE and team management and all the other topics you're going to cover are just going to just bring cardiac arrest resuscitation to the next level. I can't think of actually a more, as an ER doc, right? Like I can't think of a more practical conference, like the ability, I mean, we pride ourselves on cardiac arrest and resuscitation,
right.
But I think like anything that's going to bring new evidence, new skills, bring teamwork, practice, bring some new things into the resuscitation room that we can actually do and then bring to the bedside literally the next shift.
Absolutely.
I think it's going to be incredible.
And if you think it's interesting, sort of log on to the website, check out the list of topics, and if there's no way that if you don't look at the list of topics that are being there, that you won't be interested. So check it out. We'll put the link on the webpage somewhere, but it's Revive, and it's going to be a hell of a time.
Yeah, I'll put the link. I'm going to put the link on the Protected Airway Collaborative's website. It'll be listed as one of the events that we think you should go to, and we'll put all the links and the rest of the material online. I think that's it.
All right.
I feel pretty good about that as a first live stream from our new studio.
So honored to be the guinea pig, and hopefully this was up to scratch, and I really had just such a great time.
Thanks, guys. Yeah. So I think we were just like, all right, let's just do this. Let's just dive in and start doing live streams. We are gonna cut out here, and we will see you all on the other side of this video.